No, trust
Or
me.
get that stretch and rebound higher.
I fully understand. Kind of Starling's Law. All right. Good morning, everybody. We're going to be recording. So, again, your final exam, the official date for your final exam is next Wednesday at 8 a.m. Okay, it'll be in here. And as I said earlier, trust me, I did not pick that early date. That's the reason I filled out of college the first time back in the 70s as I had 8 a.m. classes, and I'm not a morning person. So the other thing is, again, if you want to take the exam this coming Friday from 10 to noon, you can, but you got to go in and complete that Google form that I sent out to let me know, because I'm going to have multiple people here that are taking multiple different exams on Friday. Don't have a problem with that. It's just you can't just walk in and take the exam. What I want to do today is we're going to continue with some of the review questions that we did on Monday. But in particular, what I want to do is I want to go over and stress important parts on the study guide for your final exam. So that's what I'm going to be looking at right now. In particular, first of all, any questions before we get started on anything? Okay, yeah. If you will remind me right at the end of the class, I'll try to pull that up. That was on my list to look at before you came in today, and I didn't get to it, but I can look just before we get finished. In particular, what I want you to do, and here's the thing I want to stress to you. As you've seen with the review questions, most of the review questions have been scenario based, and that's the way your exam is going to be as well. I started going through the exam again last night to make sure that it is lining up with this document right here. Okay. But again, if you're just memorizing facts and figures and details and vital signs, and you're not prepared to take your time and go through the scenarios that are on there, you're probably not going to do really well on the exam. But here's the other thing I want to stress to you. Most everybody's doing pretty good in this class. If you are at the 85 percentile or less, you got to do well on this exam, because this exam will either help you, maybe potentially bump you up to a B, or if you don't do well on the exam, if you're at that point and it brings you below an 80, you will not get to move on. I mean, I don't have any leeway on that. For the most part, everybody in here, not for the most part, but everybody right now is passing this course. So that's the great news on this. So again, I want to take everybody with me to the final semester there. So number one is be able to explain the pathophysiology of shock on the pregnant patient, including signs and symptoms. Understand that going through this, the lady's blood pressure drops. The lady's heart rate goes up. Her respiratory rate goes up. As the pregnancy progresses, her tidal volume has a tendency to go down. And as a result of that, she begins to become a little bit alkalotic. Now, again, why is she alkalotic? Because her respiratory rate is going up faster and she's actually blowing off more CO2. Be able, Tom, in using that information to decipher a problem that I would give you within a scenario. Also, understand that her blood volume will increase by 50% towards the end of the pregnancy. What does that mean for patients that have compensated or decompensated shock, primarily as a result of trauma? So I'm going to go through all of these. If you've got a question, and I'm not going to stop to ask you if you've got a question after each one that I'm going through, just simply raise your hand or yell out at me or throw something at me to clarify. So number two is differentiate between the normal neonate's respiratory status and the one that's in respiratory failure. Again, in this situation, I want you to be able to not only tell respiratory distress and respiratory failure, but I would also like you to be able to identify respiratory distress. So, respiratory arrest, and understand in this particular situation that if a child does not have a respiratory rate and or tidal volume that is adequate for life, we consider that to be a respiratory arrest, even though he or she may be still making minimal respiratory effort with a respiratory rate of 2, 3, 4, something along that line. So be able to identify the patient that you're going to go in and you're going to differentiate between simply giving high flow oxygen to as opposed to the one that you're going to begin to deal with as far as ventilation, up to and including advanced airway. What's the hallmark difference between preeclampsia and eclampsia? Seizures, okay? In preeclampsia, we're looking at the lady that will begin to have excessive edema. Now, understand, as the lady progresses through her pregnancy, she's going to have particularly some lower extremity edema, just as a part of the normal process of pregnancy. But in this situation, you're going to see not only lower edema, but also edema in the hands. She may have some visual disturbances. She may also have a really, really severe headache. Blood pressure will almost always be up. In those situations, your treatment for this patient is going to be, number one, turn the lights down, okay, because that helps to minimize the pain from the headache. Number two, unless you absolutely positively have to, don't run emergency to the hospital because that will raise her blood pressure on up and potentially put her over into full-blown eclampsia. Now, this is not, don't misunderstand me, and this is more from an operations perspective. I am not telling you run lights without siren. That's a recipe for disaster, okay? But what I am telling you is that use your best judgment, and unless it's absolutely necessary for this woman, now we don't want to raise that pressure up anymore. Understand, we're going to give her oxygen, okay, because again, we've got some vasoconstriction going on. And the second thing we want to administer would be the drug what? Mag sulfate. Why mag sulfate? Smooth muscle relaxant, okay? Just as a side note, remember, we also give mag sulfate for what other type of condition that's not cardiac related?
Anaphylaxis.
You're close. Not quite anaphylaxis, but asthma. So we would give it for asthma. The reason we don't want to give it for anaphylaxis is that it can drop the blood pressure, and the blood pressure is already low in anaphylaxis. But remember, if we've got a patient that has an asthma attack, and we can see that quite frequently in peds, the bronchioles are made up of smooth muscle. And so if we relax those, we open up the bronchioles and we can begin to break that down. Okay. Review the drug profile of diazepam, and in particular, understand what it does, how it affects the brain, how it stops seizures, and the side effects. I will not ask you for the pediatric dose of diazepam on this particular exam. Understand the pathophysiology behind the following breath sounds. Stridor. Stridor indicates what? Upper airway obstruction. Grunting in the pediatric patient represents what?
Refractory muscle use.
You'll probably see refractory muscle use. That's good. What else? What do those two things represent in your pediatric patient? Your borderline distress moving into failure. But severe respiratory distress, okay? Wheezing is bronchoconstriction. Rails, what kind of fluid? Thin fluid, and most of the time we see rails as a result of what? So rails could be classified as a type of pulmonary edema. So what's the most common cause of pulmonary edema? In adults, rarely will we see it in kids. Tom? CHF. So we've got some type of heart failure that's going on with our patient. And the last one is rhonchi. Thick mucus. Most of the time in kids, we see rhonchi with what? Say it again. We can see it with a RSV that would lead into what other type of disease process would have a fever? Pneumonia. Okay. Pneumonia. Excellent, Jazz. Very, very, very good. Given a scenario, be able to identify which stage of labor an OB patient is in. Remember, labor begins with the onset of contraction. First stage of labor, onset of contractions to the rupture of the amniotic sac. Okay. Second is the rupture of the amniotic sac and the dilation of the cervix to delivery of the baby. Third stage is delivery of the baby to delivery of the placenta. All right. 7, given a scenario, be able to use the right approach to patient assessment depending upon the age of the child. Go back and review in your text as well as some of the videos got on there the different types of emotional, behavioral expectations you'd have for a child based upon what age they're in. Obviously, we're hoping that we would not have a 16 or 17-year-old acting like a 6-year-old in the event of an emergency. If there is, we got to figure out why. Is there a problem with decreased oxygenation going to the brain as a result of the current incident that's occurring, or is there some type of a developmental delay with that particular patient? But understand and also understand on this what you're going to do to change up your assessment approach. Again, with very young children, what's the very first thing that we want to do as far as when we begin our assessment? Let me rephrase the question. Where do we begin our assessment? At the door. At the door. Second part, Yusef, you're exactly right. For young children, we begin at the feet. We take our time unless there is a critical reason to speed through that. And if there's a critical reason to do that, then, you could convert it and just do a rapid head to toe. Again, because the child is probably going to be very lethargic. But take your time, start the feed, let the child understand what you're doing, talk to the child, get down on their level, let the child touch some of the equipment that you have, and begin that process going from the feet up. Again, make sure that you review and you know the PALS algorithms for all the different life-threatening dysrhythmias. In particular, number 8 talks about asystole. You will need to know the drug dosage, again, for epinephrine and atropine. Make sure that you've done that. Placenta previa. Placenta previa comes about as a result of what? What causes placenta previa? Yusuf. So we have implantation over the cervix. What is the classic sign or symptom of a patient with a placenta previa? Yeah, so painless, bright red bleeding, all right? Understand and know what you're going to do for your patients that have vaginal bleeding, regardless of what the cause is going to be, as well as what you're not going to do, okay? Ruptured uterus. What are signs and symptoms of ruptured uterus? What's the most common mechanism of injury that leads to that? What kind of trauma? Blunt trauma, okay? What do you want to assess in your, we'll come back to that in just a minute. What are your biggest concerns with a ruptured uterus? Hemorrhagic shock, okay? The baby is not going to survive, okay? The chances of it surviving are almost none. Mom's chances are very, very low as well for the very reason that Bella just said. Severe hemorrhagic shock that's going to come into play here. Realize that mom will have sudden, excruciating pain. I mean, it is the worst pain that you can ever imagine. In rare circumstances, you may be able to see the outline, particularly of the baby's feet or hands, underneath mom's skin in the abdomen. This is particularly true if you have a lady that is having this baby who has not gained a huge amount of weight or is retaining a huge amount of fluid. Abruptio placenta. What are causes of abruptio placenta? What is abruptio placenta? So we have this violent tearing from the uterus. We can have a complete or a partial with that. Complete basically means one of the edges is lifted up, and your patient will have painful bleeding. Okay, it is possible for your patient to have an abruptio placenta and have no bleeding when the edges are intact. It holds the blood in there. Understand that some of the concomitant factors that come into play here as far as their history is number one, uncontrolled hypertension. Number two, use and abuse of methamphetamines. Caffeine comes into play there as well. Okay. Cigarette smoking comes into play there as well because both of those are vasoconstrictors. Yes.
So, if I heard that right, complete is when an edge tears off completely and there's most likely bleeding. And then partial is whenever there's like an isolated pocket in the middle, but the edges are all intact.
Yep. So complete, here's the placenta, here's the uterus. A complete basically has one part of it that is opened up that now is allowing that blood to escape. Okay. Partial is the edges are intact. All right. Which one, if you had to pick one, neither one of them are good, which one would you rather have and why? Tom?
The one where it's from the middle because they're going to be bleeding less.
Yeah. So basically what we can hope for is that as the pressure increases in there, it will begin to put pressure to reduce that pressure. Here's the flip side of that. If you got a water balloon and you're filling it more and more full of water, what happens is the balloon continues to expand. So it depends upon how fast the lady is bleeding. That will lead into that. The other thing that we can see with an abruptio placenta is this can also be precipitated even if mom has none of those bad factors that we talked about. Hypertension, meth use, smoking, caffeine use from blunt force trauma. Okay, so we want to be aware of that. Ectopic pregnancy, generally symptoms will start when? At what week? Say again. Earlier than that. Generally, mom will start having to begin having some pain at about the 6-week mark. Okay. Tell me about the location of the pain. Is it isolated or diffuse? Say it again. It's isolated. Why? Because it's in one of the, most of the time it's going to be in a fallopian tube. It's going to be in one of the fallopian tubes. So generally what we're looking for is lower quadrant here on one side or the other. Other thing that comes into play here is that differentiates this from like PID is isolated pain as opposed to diffuse pain for a woman that has PID. With PID, you will almost always have a fever, and with this type of pain, mom will not have the PID shovel. The walking does not exacerbate or make the pain worse. Keep in mind that we identify any female of childbearing age with abdominal pain, regardless of whether it's diffuse or isolated, upper, lower, or both quadrants, as being pregnant until proven otherwise. Because again, remember, with an ectopic pregnancy, the egg can implant anywhere in the abdomen. So literally, it could be in the upper quadrant. Most of the time, it gets hung up in the fallopian tube. That's why the lower isolated pain. This is a life-threatening emergency for mom. If that fallopian tube ruptures, she can potentially bleed to death. Premature delivery. What's your biggest concern about a premature delivery of a baby? We'll start with the baby. What are you most likely, what kind of a problem are you going to most likely encounter? Yusuf. So we're going to have some airway respiratory issues, okay? The younger the baby, the less likely it is that the baby is going to be have their lungs fully developed. Again, keep in mind that as that baby comes down through the vaginal opening, the compression and re-expansion of the lungs triggers the baroreceptors in the baby's body, in the brain in particular, to start breathing on its own. If the baby is very premature, you don't get that compression and expansion, and that is part of the problem that adds to the immaturity of the pulmonary system that would lead into that particular problem. Okay, so get your airway ready. Most of the time in a premature delivery, mom will be fine from a physical perspective, not so much from an emotional perspective. So again, be emotionally supportive of the mother as this process is going on. Number 10 is be able to explain the physiology of why we keep the baby at the level of the mother until after we cut the cord. Again, remember that the blood is still flowing through that cord. So baby here, mom here. If we raise the baby up, we can have some of the blood that backflows through the cord, especially when the cord stops functioning, and basically it's just kind of a siphon between mom and baby, and now the baby could potentially become anemic. If we lower the baby down below the level of mom, the reverse happens, and we can run into some problems with an increased blood pressure because of the increased volume of the blood in the baby. Signs and symptoms of croup. Silk cough or a barking cough. Okay. What's your treatment for croup? What your number one, number two things? Humidified oxygen. You just nailed both of them. Okay. So humidity and oxygen, it's going to be cool. That will help to deal with that. Epiglottitis. What ages do we normally see epiglottitis? Up to about 3, 5, 6, somewhere in that area. It's rare that you would see it in a child older than 6 or 7 because of immunizations. Again, parents have differing positions on immunizations, and so it is possible that you could see it in an older child. It is possible, but rare. I've never seen it. You can actually see epiglottitis in an adult, okay? Classic signs and symptoms of epiglottitis are what? Excessive drooling, fever. What else? There's a third one. Sore throat. There's a fourth one. Probably not going to hear any stridor because it's not all the way down there. Bella. Tripoding position. Okay, tripoding position. Again, in this situation, the best thing we can do is keep the baby calm, or keep the child calm. We don't want it crying. We don't want it upset. Don't start an IV on the child unless you absolutely positively have to. Take the child out into the cool night air. Most of the time, this happens late fall, early winter, and let that cool air help to reduce the inflammation. Humidified oxygen will also be another good thing. In this situation, you're probably best to let the child ride on mom's lap and have mom apply the oxygen as blow by for the baby. Um, Foreign body airway obstruction. The big thing I want you to know about that is to identify if you've got a child that has been fine and then they suddenly have stridor or snoring or an upper airway issue and there is no fever. Your first thing you need to be thinking about is an upper airway obstruction, especially in toddlers, because toddlers explore everything with their mouth. And so parents put the child down, they're beginning to crawl, they're beginning to find things that are under couches or whatever. They put it in their mouth, and now they have a sudden onset of airway distress, again, without a fever. How do we deal with a foreign body airway obstruction? What's our process for addressing that?
Partial, just try not to upset the child.
Partial is what?
Try not to upset.
Yeah, if it's a partial obstruction and they're still coughing, sputtering, making any sound, encourage the child to continue to cough. What if it's a complete obstruction? There's no sound that's coming out now whatsoever. What's your first plan of attack? Back slaps and not abdominal, chest thrusts. Back slaps and chest thrusts, okay? And again, this depends upon the size of the child, okay? If it is a child that is early school age, we're not going to do the back slaps and chest thrusts. We're going to go straight to doing what? Say it again? Chest compressions, okay? If that doesn't work, what is your other alternative? You actually have two alternatives, but what would be your next alternative? What do you think, Catherine? Say again. Okay, that's all right. Use your BVM. Try to right main stem whatever the obstruction is. Try to blow it into the lung. 99 times out of 100, it's going to go into that right main stem because the right main stem is straighter than the left. Child can live perfectly fine with one lung until they get to the hospital and get transferred to a higher level of care. They'll go in, do a bronchoscopy, grab whatever it is, and bring it back out. But again, that would be the thing you would do. If that doesn't work, you're left with what final approach? Crike or a surgical airway, okay? And the danger with a crike on a very young child is what? Yeah, they don't. There's really no landmarks, you know. I know, Yusuf, you've got a small child. Assess your child's trachea sometime and see what it doesn't feel like. I think when you do that, you'll find it does not feel anything at all like ours. And so that's going to be one of the more dangerous things that we're going to be able to do, and especially on very, very young children. Good job. Diaphragmatic hernia. What is our key thing that we're looking for as far as our patient assessment with a diaphragmatic hernia? First of all, what is a diaphragmatic hernia?
Isn't it a hernia that gets worse with the diaphragm spinning, stretching? Like it looks like it's breathing.
You're close. So diaphragmatic hernia is either an actual opening or a weak spot in the diaphragm that allows the intestinal tract to move up into the lungs. So remember, we talked about this in trauma. It's very, very similar to what we talked about as far as a lacerated diaphragm that allows bowel to go up into the chest. What are two things that you might, and I stress here, that you might be able to find on your assessment of this patient, in particular in your secondary assessment or your rapid head to toe?
Bowel sounds in the chest.
Bowel sounds and what else?
I just said bowel sounds in the chest.
Bowel sounds in the chest, that's one. What's the other one? Think about the anatomical change that has taken place. Bowel sounds in the chest would be that one, but what else? Let me rephrase it. What else might you not be able to hear?
Lung sounds.
Yeah, so you may have diminished lung sounds. Why? Because, again, the bowel has come into the chest. It's compressed the alveoli. There's no air that's moving around in there, okay? Pierre-Robin syndrome is basically a child is born with a small head, small jaw, and great big tongue. There can be some developmental delays with this child as well. The other thing to kind of keep in mind is the big issue when we have a Pierre-Robin is airway. Severe dehydration. What are you going to see with a child that has dehydration that's going on? Signs and symptoms. Same as an adult.
Sunken fontanelles.
Sunken fontanelles in the infant. Very good. What else? Tom.
Like delayed cap refill.
Delayed cap refill. Bella.
Less urine output.
Less urine output. What else? These are all good. What else?
Skin turgor.
Skin turgor is going to be in the trash. What about their heart rate? Elevated or depressed?
I'd say elevator.
Okay. Initially, it would be elevated, but for progressing on into irreversible shock, it could be depressed. But you're exactly right. Initially elevated. Same way with their blood pressure. Initially, their blood pressure will go up, and then it begins to fall. In the pediatric patient, what are the two most common causes of dehydration?
Diabetes.
It's number one, and number two is, or that's one, not that's number one, but that's one of them. What's the second one?
Abuse.
Not abuse. We can see it most definitely with abuse or from neglect, but that's not the most common. What else? What would be a common cause of dehydration in your pediatric patient?
Fever.
Fever. Along with that fever, maybe vomiting and diarrhea, some type of GI problem. All right? Excellent. We'll talk about fever when we talk about febrile seizures in just a minute. With meconium staining, does this always indicate that you have to get really aggressive with the baby's airway? No. Why not, Alexis?
Because if we're airway, it doesn't always block the airway completely, so it could be fine with stimulation.
Very good. Yeah, we used to go, I like to say we used to go nutsy cuckoo when we had a baby that was born that had any meconium on it whatsoever. Quite frequently, those babies were not pre-hospital, but in the hospital. They were RSI'd, they were intubated, they had deep suctioning done to them, and the treatment literally was worse than what was going on. So meconium, again, is just an indicator that the baby had some type of distress during the delivery process. Most of the time, that distress is coming about as a result in the reduction of blood flow for the baby coming from mom. And so as we're dealing with this, the key here to remember is, number one, Look to see where the meconium is. If it's isolated meconium and it's not around the mouth or nose, and your baby is pinking up, it's crying, it's kicking its arms and legs, you just simply go, "Ooh, we dodged a bullet there." All right, we're going to watch this baby really close. We're going to monitor the end tidal if you've got a pediatric circuit. We're going to monitor the pulse ox if you've got a pediatric probe that you're able to utilize. If the baby has meconium around the mouth and nose, and now we begin to see some problems going on there, most likely you're not going to RSI this child, but you're going to suction as well as you can and get really aggressive with ventilation on this child. Febrile seizures. What causes febrile seizures? The rapid change in the body temp. It's not the temp itself, but how quickly it goes up. So if you've got and most of the time we see this in infants up through toddlers. If you've got a child that's spiking a fever and the fever goes up 3, maybe 4 days, the child's not going to seize. But if it goes up over, let's say, like 8 hours to 12 hours, now you're going to have a child that's going to have a seizure. As a result of that, most of the time, the seizures will be over. What is your primary treatment for a febrile seizure for a child that is postictal? Manage the airway, and oxygen will be fine. What else? Say it again.
Cool them down.
Cool them down. Now, Alexis, what do we have to be careful about when we're cooling anybody down, but especially a pediatric patient?
I mean, you don't want to do it too fast and cause hypothermia.
Very good. Okay. It'll cause hypothermia. In your older pediatric patients and your adults, if we cool them really quick, they'll start shivering, which does what? It generates heat. Keep in mind, for your young patients, especially your infants and your newborns, number one, they can't shiver. They do not have the ability to shiver. Number two, they have lots and lots of brown fat, which is garbage as far as an insulator. So you want to kind of keep that in mind when you're addressing that. We've already kind of talked about premature delivery. What is SIDS, sudden infant death syndrome? What is the pure definition of SIDS?
That can't be determined by history or autopsy.
Perfect. I could not have said that better myself. It's the death of a child. Usually it occurs prior to the first birthday of a child that cannot be determined either from the history that you're getting from parents or upon autopsy. The big thing you got to do with a SIDS death is to show compassion to the parents, okay? If you're dealing with a SIDS death and the parents want to hold the deceased child, should you let them do that?
Yeah, that's it.
Why? You're right. Tell me why you're right.
For closure.
Very much so, for closure. And that's hold that part of that compassion. Now, there is a caveat here, okay? If you're looking at this scene that you're dealing with and you suspect that this child is not a SIDS death, but instead it came about as a result of abuse, you got to get everybody out of that room and maintain the integrity of it as a crime scene. Again, that's going to be a really hard decision that you may have to make. And if it's the wrong decision, you may have to face some blowback for it if it is indeed a SIDS death. But you looked at it as potential as a crime scene. But I would much rather you err on that side rather than just letting somebody go in and to contaminate a crime scene or alter a crime scene when indeed there was child abuse that was going on. Again, I wished I had a hard and fast formula to give you for that, but a lot of that is going to come from experience. And how do we gain experience? By making lots of mistakes. Respiratory failure, we've talked about. What's a breech delivery?
When anything goes in the head comes first.
Yeah. So we can have a buttocks presentation, we can have a feet presentation. In a breech delivery, what's the best thing that we can do for mom?
Rapid help you go to the hospital.
Rapid transport to the hospital. Raise mom's hips up and allow gravity to hopefully let the baby slide back down into the vaginal canal, especially if the delivery stops. Now, it is possible, based on the size of the child here, John, that the delivery may progress, okay? But in a breech delivery, understand that that is going to be classified as a complicated delivery. And remember, one of the things I told you at the beginning of the semester is that when you're having a normal delivery, don't run license signers to the hospital. A breech delivery, not a normal delivery. So there's other things that can go wrong in with that. Cord presentation, also known as what? If the cord comes out first, or you begin to see crowning and you can see the cord at the top of the head, that's also known as a what? Prolapsed umbilical cord. What is the most common cause of a prolapsed umbilical cord? It can be too long. Okay, that's the same most common cause for a nuchal cord. What's a nuchal cord? Wrapped around the neck. Okay, so if we got a prolapsed cord, what we got to do is we got to try to get the head off of the cord, and we can. That's one of the few times when we can insert our fingers into the vaginal canal to get that pressure off. Because remember that cord is still active. The baby is still receiving nourishment and transferring waste products to mom through that birthing process until that cord stops pulsating. If we're not able to do that, can you cut the cord at that point in time? Not only can you, but you better. Okay, make sure you clamp it first. Okay, and be very, very careful again, because you're bringing a sharp object near the baby's head as well as near the vaginal canal. Definitely do not try to do this in the back of a moving ambulance. Okay. Same situation around nuchal cord. Nuchal cord often comes about as a result of an umbilical cord that is extensively long, longer than what would normally be. If you're not able to slip the cord off around the baby's head, clamp it, cut it, okay, and proceed on from there. Limb presentation. With a limb presentation, basically we've got an arm or a foot that's coming out. That typically means that the baby, instead of coming down head first and out this way, the baby's gone sideways. An OB doc can not go in, but many times he or she can manipulate the baby from the outside to move it around so that it gets into the right position. You and I can't do that. The only thing that we can do for in that particular situation is the diesel drip, get the patient to the hospital safely. Nuchal cord, we've already talked about. Let's say you're dealing with an intubated child. What are some signs and symptoms that you've got a dislodged endotracheal tube? Decrease in the entitle. Good. What else? Abdominal distension. Good. What else? No breath sounds, or one-sided breath sounds. Most of the time. Tom, do you have okay, you just stretch it. All right.
No chest rise and fall.
Or?
Chest rise and no fall.
Well, you're close. Chest rise on one side. Yeah, especially if it comes back to what you said, Austin, a while ago, where it's right main stem. All right. If if you got a pediatric patient that's on a ventilator and the tube becomes dislodged or whatever, don't be afraid to just simply begin ventilating the patient. If they've got a trach in place, don't go back and try to replace that, especially if the opening is closed up. All right. So if it's a partial trach, and that's what you're going to see quite frequently with most kids, go ahead and you can take a really, really small infant mask and attach it to the appropriate size bag, and you can get a seal over the opening there to breathe in for the patient. There's another ACLS algorithm for bradycardia. Again, know your dosing regimen for atropine. We've talked about 15 as far as the psychological, social, and emotional needs of kids at different ages. We've talked a little bit about respiratory distress, failure, and arrest, but we haven't talked a whole lot about with a drug baby. The most common drug that babies come out addicted to currently is what? Opioids. Okay. So again, remember the action that opioids has on the adult patient, and that's intensified for the child. Some things that you may see with an opioid baby is that, especially when it is born and now it's disconnected from mom, and that child begins to go through withdrawal rather quickly. Incessant crying, shivering, that is not shivering, but that is actually seizure-like activity, especially of just the arms and the legs. And so in many situations, if they're going through that withdrawal, basically the only thing we can do is hold them and try to comfort them as much as we possibly can. If it is an opioid or an opiate overdose, now we're going to go in and we're going to do the exact same thing that we would do for an adult. Narcan would be indicated for these patients. Be very careful about using nasal Narcan on a newborn. The dosing that you have in your nasal delivery system is way too much volume than what a child would need in that regard. Know the drug profile of epinephrine and diphenhydramine. Again, epinephrine you'll need to know for the drug dosing for cardiac arrest, not for treatment of anaphylaxis. But again, know that in anaphylaxis, we're looking at a vasoconstrictor and a bronchodilator. Okay. Then we follow that up with diphenhydramine, that it takes longer to begin to work, but it also lasts longer as well going on in there. Powell's algorithm for PEA, same algorithm as what you would see for asystole. Powell's algorithm for pulseless VTAC and VFib. You do need to know your defibrillation doses for the pediatric patient. And then again, for VTAC with a pulse, in that situation, you do need to know what drug or drugs you will use in that situation. I will not ask you any questions regarding dosing on those drugs unless it involves atropine or epinephrine. What's a big problem with prolonged suctioning of, in particular, young patients, but this is true for any patient? Two things that happen. What are they? Neither one of them good.
You can have vagal nerve stimulation.
So we have vagal nerve stimulation, which results in
Increased vagal tone.
bradycardia. So that's the thing. Good discussion. What's the other thing that happens with prolonged suctioning? We're taking oxygen away. Okay. It used to be said we don't suction for any longer than 10 to 15 seconds. Well, if a baby is still full of gunk at second 21 through 28, we haven't done the baby any good. So we're still going to suction, and we're going to get that out as quickly as we possibly can. And the last one I got on here is review the drug profile of mag sulfate. Know what it does, how it does it. You do not have to know the drug dose for mag sulfate in eclampsia, okay, or preeclampsia. All right. Know that That is our drug of choice to give to our patient if they begin having a seizure. Question: if it's a smooth muscle relaxant for mom and we give it, what are some of the side effects that we want to be aware of as far as mag sulfate goes that could be detrimental to both mom and baby? Remember why we're giving it. Remember the mechanism. We've already talked about it earlier. It says a smooth muscle relaxant. Tom.
Hypotension.
And good. Hypotension would be one. What would be the other? Bella. Yeah, it would decrease our preload. You're exactly right, which ties in with our hypotension. But again, what happens with any drug that we give for seizures? What's the risk?
Airway.
Not so much airway as much as breathing. So you're in the right neighborhood. So yeah, so remember that mag sulfate can depress the breathing centers of the brain. That's true of mom. That's also true of baby. Okay? And ladies and gentlemen, we've been going for about 55 minutes. That's where we're going to stop because I think we're all pretty much exhausted. Yes, sir.
What's the half-life of magnesium?
That's a good question. I don't know. So again, carry an app with you because I think the point that you bring up there is a critical one in the fact that we want to kind of have an idea of how long we're going to have to deal with these problems when we give a medicine. Now, understand that the half-life for a fetus that's still in utero, that may be extended out a little bit longer. So that's a very good question. Anybody else? Yes, ma'am. Yes, I will do that right now. Hold on just a minute.